Hi everybody, this will be a brief talk on Cauda Equina syndrome. So this is going over a bunch of spinal cord lesions. We've gotten to Cauda Equina syndrome now. I've got other talks on these other topics, and these make up pretty much all of the spinal cord lesions that you're going to see on the USMLE. With the exception of ALS, which I'll give its own special attention. Okay, so Cauda Equina syndrome. First, we should know what the Cauda Equina is. So you probably remember from first year anatomy that the Cauda Equina is a set of nerves, intradural nerves, and they provide sensory and motor innervation from L2 to S5. So the Cauda Equina extends from L2 to S5, and S5 is the end of the spinal cord in as much as it's the end of the nerves in the spinal column. So the spinal cord itself, as we know it, as these sections of spine, that ends at L2, but the end of the nervous system is S5. So Cauda equina, just for reference, is Latin for horse's tail, and it's because it has kind of a similar appearance to these hairs coming out of the horse's tail. And the spinal cord tapers off, as mentioned, at L2, and that's called the conus medullaris. And after that, the nerves all derive from the Cauda equina, and that goes all the way down to the very end, which is S5. So nerve roots of the Cauda equina provide sensory and motor innervation to pretty much all of the lower extremity and to the anal and urinary sphincters and to the genitalia. So hip muscles, lower extremity muscles, urinary and anal sphincter muscles, and muscles important for sexual function, as well as sensory innervation and pain innervation. So this is just a schematic of the Cauda equina. Here we are, T12. We end at L2. This is the conus medullaris, where the spinal cord tapers off. And then this is my rough representation of the Cauda equina. So we have these intradural nerves. They ultimately will form nerve roots L3, L4, L5, all the way down to S5. There is a fiber that attaches the conus medullaris to the sacrum, and that's called the filum terminale. So you may hear that word thrown around. By far, the number one cause of Cauda equina syndrome is disc herniation. And the most common place to have a spinal disc herniation are between L4, L5, and L5S1. So, Cauda equina syndrome. Nerve roots of the Cauda equina, as mentioned, provide sensory and motor innervation to the lower extremity, to the genitalia, to the sphincters. And the most common cause of Cauda equina syndrome is herniated nucleus pulposus, which is just the fancy name for slip disc or disc herniation. Some other causes include lumbar stenosis, particularly lumbar stenosis caused from osteoarthritis, which is one of the most common diseases that happens in aging. You can also have lumbar stenosis that's congenital and developmental. Trauma is another possible cause of Cauda equina syndrome, either ballistic trauma or penetrating trauma. Neoplasm or metastasis. Usually it's going to be metastasis to the spine, but you can get a neoplasm of spinal tissue. Most commonly, that's going to be an ependymoma, and that, if present, usually occurs in a younger male. You can also have schwannoma as well. Infection or abscess may cause Cauda equina syndrome, and then there's also various inflammatory diseases such as ankylosing spondylitis. Now, the symptoms are going to vary based on what the underlying cause is and the level at which the lesion is compressing the nerves. So where you have your weakness, pain, where you have your sensory loss, that's going to be based on the level you're at. And then the other symptoms that you have in addition to your weakness and sensory loss, that's going to point you towards the possible underlying cause. So Cauda equina syndrome is not a diagnosis in and of itself. It is the manifestation of symptoms due to another pathologic diagnosis, such as a slipped disc or a neoplasm. But in all Cauda equina syndromes, there's always going to be some sort of weakness, some sort of sensory deficiency or anesthesia, and then some sort of pain. That's always going to be present in Cauda equina syndrome. So what is the history in a patient with Cauda equina syndrome? Most commonly, they're older because as we age, the intravertebral discs tend to degenerate. And so because the intravertebral discs start to degenerate, that increases the risk of disc herniation. So age is itself a risk factor for Cauda equina syndrome. Now, if a patient has an acute Cauda equina syndrome that came on suddenly and is very, very strong, they may have a history of trauma because the trauma would immediately cause damage to the nerves. And then also cancer is another possibility if the patient has a metastasis to the spine or symptoms consistent with cancer. Not all the times on the USMLE they're going to tell you the patient has cancer. So if the patient has symptoms consistent with cancer and they have Cauda equina syndrome symptoms, it may be that cancer has now spread to the spinal cord. Chronic Cauda equina syndrome often has a chronic, dull lower back pain, even though the sensory and motor symptoms aren't as prominent. It may be the pain that's more prominent. Symptoms include lower back pain. There may be pain that's due to compression of the nerves that's referred elsewhere in the lower extremities. There's always going to be a unilateral or bilateral lower extremity weakness or sensory deficit. There'll tend to be a pain, if not in the lower back, then likely in the lower extremities or even the feet. There may be, depending on the location of the lesion, a loss of sphincter tone, which can result in either urinary or fecal incontinence. Sexual problems, such as erectile dysfunction, may be a symptom, particularly if it's affecting the levels of L2, L3, and L4. Because this is affecting the lower motor neurons, it can cause fasciculations of muscle, and there are almost always reduced or absent deep tendon reflexes. Of course, this is all going to be based on the location of the lesion, where it's at in the spinal column. So that's going to tell you where the deficit and weakness is, and vice versa. Where the deficit and weakness is will help you estimate where the lesion is. On physical exam, you'll have a reduced lower extremity strength. That may be in the thighs, that may be in the hips, or it may be in the feet and toes, just depending on what level it's at. You're going to have reduced sensation over particular dermatomes, again, depending on where the lesion is at. You can have reduced or absent deep tendon reflexes. If it's not at a level that necessarily causes a deep tendon reflex loss, you may have different reduced or absent reflexes. So there's a couple important ones that are good to know about. One is the cremasteric reflex. That's at L1 and L2. And a lot of times L2, if you have a lesion at L2 or L3, you're going to have an absent patellar reflex. But if the lesion is higher, if it's at L1 or L2, you will often have a reduced or absent cremasteric reflex. And this is only really useful in men. And what a cremasteric reflex is it's when you stroke on the superior medial thigh, what you get is a contraction of the cremaster muscle, and the cremaster muscle causes that ipsilateral testis to raise up, to elevate. So if you strike, or if you stroke the right superior medial thigh, the right testis will elevate, and that's the cremaster reflex. If it's absent, that points to a lesion at L1 or L2. And this is, of course, only really useful in men because we can't see the testis of the woman, which, of course, the equivalent would be the ovary. Now, the bulbo cavernosus reflex, it can be used both in men and women. It can be looked for, but it is, again, a little easier to find in men. What you can do is, this also measures S2 to S4. Some texts even refer to it as reflecting S1, but definitely S2, 3, and 4. And this is, what you're doing here is you're going to squeeze on the glans penis, or tug on it, or what you can do if the patient has a urinary catheter in, and this, of course, you'd have to do if the patient were a woman, you can tug on the Foley catheter. And what should happen from that, if you have an intact bulbo cavernous reflex, is that you would get contraction of the anal sphincter. And so by contraction of the anal sphincter, what that means is that the anal cavity or anal canal should get smaller in diameter. When you relax the anal sphincter, that's like you're going to the bathroom. So it gets larger. When you contract it, it gets smaller. So, because our anal sphincter is in a constant state of tone. So, if you stroke the glans penis or squeeze it, and then tug on the Foley catheter, what you should get is a anal sphincter contraction. If you don't get that, then that is consistent with damage to S2 to S4. And this, a lot of times, takes a really experienced clinician. Another good way that I found to test for this is to put a glove on your hand and take your finger and just insert it slightly just past the anal sphincter muscle. So you're not going up very high. It's not like you're checking for their. You're not doing like a rectal exam on them. Just stick the finger just slightly into the anal canal past the anal sphincter, and then do your test by either squeezing on the glans penis or pulling on the Foley catheter, and you should feel some contraction of the anal sphincter. If you don't, then that indicates an absent bulbo cavernous reflex, and that would be damage to S2 to S4. So those two are some tests that can be clinically useful that aren't your typical patellar reflex or Achilles reflex that you learn in medical school. Okay, so for diagnosis of Cauda Equina syndrome, all patients with symptoms consistent with Cauda Equina syndrome, meaning the weakness, the pain deficit, or the pain or the sensory deficit, they should all get a lumbar spinal MRI. And this is going to help us diagnose if there's a slipped disc, if there's a tumor, etc. So provided that the patient is stable, not obviously if the patient has a knife wound, if the patient is stable, this is going to be the best first step in diagnosis, and it's going to generally be the most accurate test. Actually, it'll always be the most accurate test in diagnosing Cauda Equina syndrome. The underlying cause also is going to need to be found. A lot of times we will find it on the MRI, but if the cause is infection, we're not going to find necessarily the underlying cause, because in that case, the most accurate test will be some kind of culture, like it always is in infectious disease. So if, for instance, the patient has meningismal symptoms, then you're going to want to get a CSF analysis. In practically all patients, a chest x-ray is going to be indicated because the most common place that, it is the most common cancer pretty much overall, and it's the most common cancer to metastasize to the spine is the lungs. And it's very common in the U.S., so a chest x-ray is often indicated in addition to the MRI because the chest x-ray can help us rule out lung cancer. So a chest x-ray is generally indicated, but the best first step in working up Cauda Equina syndrome, provided you have a patient who's stable, is going to be a lumbar spinal MRI. And by lumbar spinal MRI, I mean also including the sacral levels too. So lumbosacral MRI. The differential for Cauda Equina syndrome are going to be multiple different neurologic diseases. So Guillain-Barré syndrome, this also involves paralysis or weakness, and also is going to involve reduced or absent deep tendon reflexes. However, with Guillain-Barré syndrome, it's always bilateral, whereas with Cauda Equina syndrome, it may be unilateral. And with Guillain-Barré syndrome, it's not accompanied by clinically significant sensory deficits. Guillain-Barré syndrome also is sort of a chronic thing that ascends over a period of a week or 2 weeks. And a lot of times with Guillain-Barré syndrome, there is often a recent infection, either diarrheal or an upper respiratory tract infection. If you get a lumbar MRI, the spine should be normal. And if you get a cerebral spinal fluid, which is the best way to diagnose Guillain-Barré syndrome, you'll have an elevated protein level but no cells. Amyotrophic lateral sclerosis, or Lou Gehrig's disease, also involves paralysis or weakness and fasciculations as well. With ALS, it's not accompanied by clinically significant sensory deficits, and with ALS, you may see upper extremities or facial and bulbar symptoms. And the lumbar MRI should be normal. There shouldn't be anything compressing the spine. There shouldn't be any tumor. There shouldn't be any slipped discs, etc. Multiple sclerosis can also involve weakness of the lower extremities and feet. This tends to be in younger patients. With multiple sclerosis, it usually comes on insidiously. The symptoms can come and go. And often with multiple sclerosis, there'll be some kind of eye involvement. So you may have pain on movement of the eyes, or you may have double vision, diplopia. Lumbar MRI will be normal. This is not a disease of the peripheral nervous system. Multiple sclerosis is a disease of the central nervous system. So if you were to get an MRI of the brain, in multiple sclerosis, you should see enhancing white matter lesions. If you look at a sagittal section of the brain on MRI, you should see Dawson's fingers projecting from the ventricles. Diabetic neuropathy can also involve pain and weakness of the lower extremities, particularly pain. These patients are going to have a history of diabetes, particularly uncontrolled diabetes. So if they have labs, a lot of times you're going to see an elevated glucose, maybe an elevated A1P. They also might have renal function, which is off and uncontrolled. And then a spinal neoplasm is another possible this is actually a cause of Cauda Equina syndrome, but it deserves mention as its own diagnosis since this is so significant. But this will be differentiated on MRI. And as mentioned, the more common neoplasms are ependymoma and schwannoma, ependymoma being the most common. Treatment for Cauda Equina syndrome is going to be based on the underlying cause, which should be discovered via workup, particularly with MRI. As mentioned, the number one cause of Cauda Equina syndrome is a slipped disc. Patients should be referred to the appropriate specialist based on their underlying cause, so that may be neurosurgery, it could be oncology, it could be orthopedics, it could be a rheumatologist, and so forth. You should be extra careful not to delay consultation to a neurosurgeon for surgical intervention, particularly in patients with obvious trauma to the lower back. So if there is a knife wound to the lower back and the patient is showing symptoms consistent with Cauda Equina syndrome, they should be immediately referred for surgical intervention. The mainstay of treatment in general, though, for patients with Cauda Equina damage is going to be rehabilitation with physical and occupational therapy, and then, of course, treatment of the underlying cause. Okay, so this is a little cheat sheet for your lumbar and sacral roots. And there's obviously a lot of information on here based on the root, if it's damaged or if it's not working properly, where you're going to get sensory abnormalities, where you're going to have pain, where you're going to have motor deficits, and where you're going to have a reflex deficit. And there's some overlap on here, so it's really difficult to it's difficult to localize all of these roots to one location because they take care of different things sensory-wise, different levels motor-wise. So what I put here in quotes under L2, L3, etc. is probably the best generalization. So L2 in general tends to operate the thigh and knee medially. L3 tends to operate the thigh and knee laterally. L4 tends to operate the thigh and knee posteriorly, and then the foot as well. L5 takes care of dorsiflexion of the feet and toes. S1 through S2 takes care of the lateral foot and plantar flexion. Remember, plantar flexion is like standing on your tippy toes. And S3 through S5 takes care of the sphincters and the genitals. Now, L2 through L4, remember, is responsible for your cremasteric reflex, and it's also responsible for erection in men. So men with damage to L2 through L4 will have a deficient cremasteric reflex, which obviously they're not going to notice at home, but what they will notice at home if they have a married or active sex life is they're going to notice that they can't get an erection. So L2, 3, 4 gets your pants on the floor. That's kind of a dirty way to remember it, but that's how you can remember L2, 3, and 4 is responsible for sexual function in men. And then, but apart from that, for the genitals and for the anal and urinary sphincters, it's going to be S3 through S5. That takes care of the sphincters, and that will result in your bulbar cavernous reflex deficit, obviously, if you don't have it. Your patellar reflex is taken care of by L3 and L4. So if the patient doesn't have a patellar reflex, which is the most common reflex we test for, then the damage is at L3 or L4. So you can decide to go through this as much as you want. What I highlighted is what's most important. The stuff in the quotes will help you know for most of it. And then I would remember L2 through L4 being important for an erection, and definitely know that S3 through S5, the very end of the spinal cord, is responsible for your anal and urinary sphincters. And that's it for Cauda Equina.